Good day, everyone. My name is Dr. Gamafoy. Today we are going to discuss about hemodynamic disturbances. But before we dive into the disturbances, which is a pathology, we are going to fresh our mind with the physiology of the hemostasis, but in a nutshell, not in detail. Just we are going to brush about the physiological aspect that will help us in understanding the hemodynamic disturbances in a better way. So, for a normal coagulation to occur in the blood, or for a normal blood clot to happen in a blood, that is to stop bleeding, we need two things. We need platelet and we need clotting factors. The platelet, they are the one that will cause the primary hemostasis. You can remember your physiology, right? While the coagulation factors, they are the one that will now tie up the bunch of the platelet, because the platelet used to come in group, make a clot, right? But the clot is primary, is unstable. So it is the clotting factors now that will end up activating fibrinogen into fibrin. The fibrin is a kind of thread-like substance. It is just like this, thread-like substance, like this. It will make the clot stable because by tying it up, right? So let us start with the clotting factors. We have clotting factors from 1 to 13. So they are 13 in number, almost all of which are produced by the liver, actually. Not all of them, but almost all. But for example, like the fibrinogen, factor 1 is produced by the liver, factor 2, prothrombin, also by the liver, tissue factor from that tissue factor, that is tissue. So that means normal tissue, if you damage your hands, normal in the cells of your hand, or in your leg, or in your stomach, or in your pancreas, you have tissue. Everywhere you have tissue in your body, because any organ is made up of tissue. Skin is an organ that is made up of tissue, right? So in all these organs, they can produce tissue factor. So that is it. Factor 4, which is calcium, factor 5 from the liver, factor 6, 7 from the liver, factor 8 from the vascular endothelial cells. This is the VEC, vascular endothelial cells. The cells that made up, because we have a kind of cell that lines the blood vessels, right? So those blood vessels, they are having a kind of endothelial cells, if you can remember your histology. So that endothelial cells, they are the one that is produced, that are producing this factor 8, not liver. So if someone is having liver problem, he will have deficiency of almost all the factors, but factor 8 will be there. Factor 8 and factor and tissue factor, right? And factor 13 also. But from factor 9 to factor 12 are all from the liver. Factor 13 also from platelet. So for the platelet now, the platelet, for the platelet clot to occur, that is the primary hemostasis. Let's say this is the normal blood vessel. This is the blood vessel that get damaged. As you can see, this is the white things. Let me change the color. Okay. So this is the white thing you are seeing. I'm coming. This is the white thing you are seeing. So this is the platelet that made a clot in the area. So for the platelet to make a clot, normally in the blood vessels, if the blood is moving in a blood vessel, the blood cells are moving centrally, not periphery of the blood vessel. So, but the periphery, like this area and this area, periphery of the blood vessels, it is the plasma that is moving in that area. But at the center of the blood vessels, it is the blood cells at the center. So, if there is injury to the blood vessel will now release, that's the endothelial cells, will now release some kind of things. For example, thromboxane A2, endothelin, all these factors that will constrict the blood vessel and narrow it. If the blood vessel is narrowed, so now they will attract the platelet toward the injured side. So the first platelet to come, it will activate it, the rest of the platelet, it will call the rest of the platelet by releasing substance called ADP. Yes, the first platelet to come will release substance called ADP. This ADP will attract more and more platelet, so that to make this kind of clot to happen. That's the primary hemostasis. So that is it. So if a lot of platelet come to the site, it is called an aggregation. So they will extend something called pseudopod. This pseudopod is just like a kind of foot process. This is it. This is a pseudopod, right? This is a pseudopod. Yes, this is another pseudopod. So this pseudopod is the one that will use to adhere the one platelet to another platelet. One platelet adhere to another platelet using this pseudopod. So this is it. This is a normal blood vessel. This it has get injured. In this case, platelet has arrived. See them, bunch of them. They made a kind of primary hemostasis. But in this case, there is what black thing you are seeing at the top of the platelet. Yes. So this white black thing you are seeing at the top of the platelet in this case, so it is the fibrin, and that fibrin cannot be formed without the activation of the clotting factors. The clotting factors that are there are the one that will activate the fibrinogen, that is the factor 1, right, into fibrin. So that fibrin is a mesh made like it's a kind of thread-like substance, as I have said. It will come and tie up the platelet, so that to make a what secondary hemostatic block, so that to stabilize the platelet. That's the function. So for the coagulation pathways, we have the extrinsic pathway and we have the intrinsic pathway. So for the extrinsic pathway, it need factor 3, which is a tissue factor. Then tissue factor will now activate factor 7, and then the factor 7 will now activate factor 10. So that factor 10 is the one that will activate the prothrombin. What is the factor prothrombin, which is a factor 2, right? And then prothrombin will be activated into thrombin. So that means factor 3, which is a tissue factor, together with factor 7, they will activate factor 10. Then factor 10, activated factor 10 will convert prothrombin into thrombin. And then thrombin will now take factor 1, which is the fibrinogen, and convert it into what? Into fibrin. So the coagulating factors that are involved in extrinsic coagulation pathway, we have the tissue factor, factor 7, right? And factor 10. So that is it. So while in the intrinsic coagulation pathway, it is the factor 12, the initiator factor, which is a protease actually. So the factor 12, XII, right, is a Roman number. So it is the initiating factor. So it is the first factor to be activated. That is what they mean by initial factor. So this factor 12 will activate factor 11. Factor 11 will activate factor 9. Factor 9 will activate factor 8. And then this together they will activate factor 10. So the factor 10 will now activate the what? Prothrombin into thrombin. Then thrombin will take fibrinogen, which is a factor 1, and activate it into fibrin. So if you can remember, that means intrinsic pathway and extrinsic pathway, they all meet as a point of activation of what? Factor 10. So that means there is factor 10 activation in both the pathways, factor 10 and factor 8, and extrinsic and intrinsic pathways, they all activate factor 10. So that is, and then you have to remember that calcium is also needed and factor 5 as a cofactors also. So that is it. So we have coagulation system disturbances. When we say coagulation system disturbances, there is, as we have already know, that an equilibrium has to be maintained. That is, a stable equilibrium has to be maintained between the factors that like the blood to clot and the factors that like the blood not to clot, or that they don't like the blood to clot. So the factors that like the blood to clot, they are called procoagulant factors, like the platelet, the coagulation factors. All these factors like the blood to clot. But the factors that they don't like the blood to clot are called the anti-clotting factors. We have the protein C, protein S, antithrombin 3, plasminogen. So all this they don't like the blood to clot. And an equilibrium has to be maintained. A balance has to be maintained between the two. If there is excessive production of the factors that they don't like the blood to clot, that is the anti-clotting factors. So we will have bleeding, excessive bleeding, right? If we have failure of production of the factors that they like, if we have excessive production of the factors that like the blood to clot, So we will have thrombosis. We will have an excessive uh, coagulation in the body, right? So now let us start with the bleeding tendency first. So excessive bleeding tendency disturbances, that's abnormal bleeding. They can be hereditary, number one, and they can be acquired. So now let us start with the hereditary. The two categories here, we have the hemophilia and then we have the von Willebrand disease. So now let us talk about the hemophilia first. Hemophilia is a kind of X-linked. When we say X-linked disorder, it is actually seen in only males. It is hardly to see it in female, if not even to say impossible. It is hardly to see it in female gender. You will see it in only male gender. Any X-linked disease. So this hemophilia occur due to, and then this hemophilia is manifested by an excessive bleeding. A person will have small injury, just small injury that didn't even uh, deserve to even bleed, but he will start bleeding excessively. So what causes this hemophilia? We have the hemophilia A, which is due to deficiency of factor 8, right? Uh-huh. And we have said factor 8 is produced by what? Vascular endothelial cells. So if a person cannot produce factor 8, from there you can remember by factor 8 as if you are saying A, right? So that means hemophilia A occur due to factor 8 deficiency. We have hemophilia B due to factor 9 deficiency. Factor C, hemophilia C due to factor 11 uh, deficiency. So manifest as internal hemorrhage, that's clinical manifestation, and unstoppable bleeding. Person will be having a kind of an unstoppable bleeding. The internal hemorrhage, as in this case, this is a knee of a patient. This is a knee joint. This is called hemaarthrosis. This usually come out in an exam. If they want to test you about hemophilia, they will bring this picture, a knee that it has swollen up, and they will say is a person, and the knee used to be unilateral, not bilateral. So they will say this is a swelling, maybe 12-year-old boy, blah blah blah. So they want you to pick up hemophilia in the option in most cases. So that is it. Though we have a lot of differential diagnosis, for example, septic arthritis can also manifest with this unilateral joint swelling. But if they want to elaborate to you and make you to understand it is hemophilia, they will say the blood is collected, a needle is passed, and then blood has been withdrawn from the needle, from the joint. So when we see this, definitely is hemophilia. So that is it. But for you to know which type of hemophilia, now you have to measure the amount in the blood. You have to measure the factor 8, you have to measure the factor 9 and 11. So that is it. And that one, you have to measure something called PT and PTT. So that's now we are not doing internal medicine, just we are doing the pathology. So that's it. And where a person will have this bleeding from the joint, as we have already know that without having an injury, without you don't need to get injured for your blood vessels to get damaged, especially the blood vessels of this joint, because of the friction every day you are working with your legs. So some blood vessels, every day some blood vessels used to get damaged and repaired without noticing it, without us noticing it. So and this repairing need these clotting factors, right? And you can remember, you can see that all these clotting factors that are involved in hemophilia, they are found in intrinsic pathway, not extrinsic pathway. So that means hemophilia is an disorder that affect the intrinsic pathway of the blood coagulation. So this is the von Willebrand disease. As we have known, if this is a platelet, in the surface of platelet we have something called, on its surface we have uh, glycoprotein 2b and glycoprotein 3a, GP2b slash 3a. This is the platelet. In this platelet, it will use this GP3b slash 2b3a in order to adhere to this von Willebrand factor, and this von Willebrand factor is produced or is uh, uh, synthesized by the vascular and endothelial cells, right? So these vascular endothelial cells that are the one that produce this von Willebrand factor. If a blood vessel is damaged, the cells of the blood vessel, they will release this von Willebrand factor, and this von Willebrand factor platelet will use it and adhere to the blood vessels, so they will make this blood clot. So without bone willibrand factor, the platelet cannot adhere to the injured blood vessels, right? So that is it. So it is a platelet that is having this GP2B 3A, not the bone willibrand factor. This thing. So I'm emphasizing also this. If you measure the level of factor 8 in the body of the person, you will find it in a person that is having bone willibrand disease. So you will see that you will find out that factor 8 is also decreased, because the integrity of vascular of the factor 8 is maintained by this bone willibrand factor. So without the bone willibrand factor, definitely you will have the integrity of this will decrease, so it will be almost there, almost not there. It will also decrease. So that is it. So this is the acquired, right? That's the second category of the bleeding tendency related disturbances. Uh, Clotting factors deficiency or coagulation factors deficiency can occur acquired, not born with, can be acquired later in life, not born with it, like as in the case of hereditary, in two ways. Number one, if there is decrease in their production, that is production disturbances, or if there is increase in their destruction, or is increase in their usage. If you use them excessively, you will consume them off, right? If you don't produce it, you will still have deficiency of them. So that is it. So what causes decrease in the production? For example, if someone is having liver failure, if there is liver failure, so definitely you cannot synthesize uh, factor 1, factor 2, factor 5, even factor 7, even factor 9, 10, 11, 12. All these factors cannot be produced. So definitely someone with CLD, chronic liver disease, will have this bleeding problem. He will be bleeding excessively. And then consumption increase. If there is increased consumption or increase in their loss, for example, if someone is having DIC, which is known as uh, uh, disseminated intravascular coagulation, so DIC, he will consume up all his clotting factors. If you consume it all before you synthesize new ones, definitely you will be having bleeding. Because as I have said, almost every day a person has a kind of damaged blood vessels. Some small blood vessels are get damaged due to the friction of the blood. So if you consume all the clotting factors, now what will repair the blood vessels? Nothing, right? So the person will be having bleeding. So this person with DIC will be having excessive clotting in his blood and he will be bleeding at the same time. So that is it. So, and also in this case, consumption in increase. Apart from the DIC, what will cause increased loss? Loss, OLOSS. For example, if someone is having nephrotic syndrome, in nephrotic syndrome, a person will be losing his protein, right? Like albumin, fibrinogen. He will be losing a lot of uh, protein in his blood, from his blood, right? So he may be losing a lot of proteins from his blood into the urine. So he will be losing together with the clotting factors, right? So definitely he will have decrease in clotting factors or deficiency of them. So now let us discuss about the thrombosis related disturbances. In that case, or in the earlier, we have discussed about causes of excessive bleeding, excessively hemophilia, von Willebrand disease. I forgot to say von Willebrand disease is inherited as an autosomal dominant. That means male and female can both get the disease, and you need only one abnormal gene to get the problem. Yes, you don't need two, as in the case of recessive. For example, sickle cell disease. For example, sickle cell disease. A sickle cell patient has to inherit two abnormal hemoglobin before he became SS, before he became uh, uh, patient of sickle cell, or before he became sickler, right? But because it is an autosomal recessive. But one willibrand disease is an autosomal dominant. Even one, if you inherit single abnormal gene, you will have the disease, and it occur unlike the X-linked. It can affect female and it can affect male. So there are some factors that they don't like the blood to clot, which are the antithrombin 3, protein C, protein S. So all these are the major, but we have the plasminogen. This they prevent clotting, while the plasminogen, if it is activated into plasmin, let us see the factors. Yes, this is number one. We have the tissue factor pathway inhibitor. From what tissue factor pathway? Which is the factor is a tissue factor pathway? Is the extrinsic, right? So inhibitor, when we say inhibit heparin. Heparin, this is heparin is a drug. We have the synthetic one, that is artificial one, and we have the heparan sulfate, the heparan that is synthesized from the liver. But we have the heparin that is synthesized artificially. We have the antithrombin 3, we have the protein C, protein S, we have the plasminogen. This is fibrin degradation protein. So all these factors, almost not all, but this, especially this plasminogen, this will not prevent the blood clotting. Its function is mainly destruction of the clot. If there is clotting here, the plasminogen will going to be activated by the tissue plasminogen activator, or called TPA. So it will destruct this clotting. It will dissolve it. While this prevent from the clotting to happen, it even they prevent the clotting from even happening. So that is it. So in case of hereditary factors that cause this thrombosis, we have if there is deficiency of antithrombin 3, protein S, protein C. So how does this protein C and protein S prevent clotting? Because they prevent the activation of factor 5 and then the factor 8. How does this antithrombin 3 has an antithrombotic effect? By prevention of the activation of the thrombin and the factor 10. Right? So that is it. So that's yes. So this is it. This is a genetic cause, and the second category is the environmental cause of this thrombosis-related disturbances. So when we say environmental, the factors that are like not associated with directly with the mutation or hereditary things. It is acquired things. So we have labor. A woman in labor, that is parturient, right? A woman that is that is in labor. Surgery operation, especially the surgery, especially pelvic surgery, any form of pelvic surgery, cesarean section, herniorrhaphy, any form of surgery, it put a person, a pelvic surgery, it put a person on the risk of having thrombosis because of the immobility. Then any diet that is especially having a kind of fatty diet, it put a person at risk. Obesity and is associated with hyperlipidemia, a lot of lipid in the blood. So this excessive lipid in the blood damage blood vessels. So it render a person into thrombosis. Diabetes mellitus, excessive glucose in the blood. In the case of diabetes mellitus, put a person at risk. Smoking cigarette damage the blood vessels, so put a person at risk of thrombosis. Because if there is damage of the blood vessels, so the person will have a thrombosis. Malignant tumor, some tumor will be releasing excessive tissue factor. So that tissue factor will be what? Will activate the extrinsic pathway, right? Oral contraceptive pills, they will cause thrombosis because they are containing estrogen, and they will make the liver to be producing excessive amount of the clotting factors. And we don't like, and as we have said, we don't like uh, excessive clotting factors or excessive anti-clotting factors. We like them to be in a balance to maintain each other, but at balance. We don't like one to be uh, greater than the other. So this is pathogenesis of thrombosis. For any thrombosis to occur, we need three things. One of these three things, which is called Barkow's triad. When we say triad, we mean three things. One thing has to happen here for a thrombosis to occur. At least one thing has to happen. There has to be endothelial injury, as in the case of diabetes mellitus, smoking, hyperlipidemia, as I have said. we have to have stasis. When we say stasis, stagnant stop of blood in an area. If a person have his heart stop working, if the heart stop pumping blood, so the blood will remain in the heart chamber without being pumped, right? If the heart remain stagnant without working, so the blood will clot. Any stasis, any stoppage of blood will make it to clot. For example, if there is fracture of femur, if you have fracture of your lower limb or paralysis or in surgery, the person is immobilized. If he didn't mobilize his leg, for example, let you see an image. This is a vein. So this is the blood that is passing through. If you are not moving your lower limb, the blood will not go up because it is moving up against gravity toward the heart from the legs, right? If you are not moving your leg, as in the case of fracture, so the blood will stay here. If it stay here, it will cause clot. It will clot actually. So if a person is having hypercoagulative state, for example, in pregnancy, in oral contraceptive pills, in cancer, all these are hypercoagulative state. In pregnancy, there is excessive production of estrogen, and estrogen will in turn increase the excess production of clotting factors. Also are oral contraceptive pills. Also tissue cancer. Cancer will be excessively production tissue factor, right? That's the factor 3. So deep venous thrombosis. Deep venous thrombosis occur in the deep veins, especially in the legs, in the lower limb. So if the due to the stasis or anything, it will cause, especially due to stasis or stagnant blood, due to the fracture, due to the paralysis, anything that will cause the stasis. The problem is, number one, we have the obstruction of the deep vessels, which will be causing a very painful unilateral swelling of the lower extremity. In most cases, if not all cases, DVT is seen in unilateral limb, not both the legs. If you see both legs are swelling off, it's unlikely to be DVT. You can't say it's impossible to be DVT, but it's unlikely. So that is it. And you will see the erythema. When we say erythema, means reddening of the affected limb. And the person will be complaining of pain and paresthesia. Paresthesia, needle-like sensation in the leg. So complication of it, that thrombus can pinch up and become an embolus. When we say embolus, it means a piece of clot of blood that is moving in the blood. When we say thrombus, it is the clotted blood in one place is called thrombus. But if it pinch up and then moving inside the blood is called an embolus. So this thrombus, deep venous thrombosis, this thrombus can pinch up, a piece of it can pinch up and become embolus, and then obstruct the blood circulation. For example, the pulmonary, it will go to the heart, and then from the right ventricle, it can be pumped into the pulmonary artery, right? So it can clog the pulmonary artery, and the person will be having cough, will be having difficulty breathing, especially coughing up blood. That's called pulmonary embolism. But because it is due to DVT, thrombosis, you will say it pulmonary thromboembolism, because it's the thrombus that become embolus and then obstruct the pulmonary artery. So that is it. So let's say this is the pulmonary artery, this is the heart. So it will pump this thrombus and clog this area. If it obstruct this is the pulmonary artery, one branch, this is the other branch, this is the right lung, this is the left lung. So now the thrombus will obstruct this area. So if it obstruct this area, then definitely if it clog this area, right? So this definitely it will cause heart. It may even have a kind of the person will be having excessive sweating, coughing of blood, difficulty breathing, chest pain. He can die within a 5 minute or so if care has not been taken. So thank you very much. Please, if you find this helpful, don't forget to subscribe, like, and comment.